risk factors, subclinical atherosclerosis, and early detection. And what's beyond, it's my pleasure and honor to have actually a very distinguished speaker with me, Professor Wael, and I'd like to thank Bayer team for inviting me to share with Professor Wael this important event. We'll start now with Professor Wael. Professor Wael will present starting with atherosclerotic cardiovascular disease, a cardiovascular continuum.
Professor Nabil, thank you very much for the introduction. I'm honored. The honor is mine to be with you, a well-respected professor with a vast experience in cardiovascular disease. Without further ado, we're gonna go. The purpose of such webinars and is highlighting on a very important disease, which is #1 killer in the world, with atherosclerosis disease. It's a journey. I'm lucky to start with the most easy topic, which is talking about the risk factor of atherosclerosis, and then Dr. Nabil will take us for the assessment and so on. Every webinar, we're gonna dive deeply in atherosclerosis until the picture is completed. So next, the content of my lecture is #1 and 2, atherosclerosis and cardiovascular disease, and then I will touch base quickly the role of lipid and inflammation, atherosclerosis, and atherosclerotic cardiovascular disease. A lot of talk, a lot of research is going on, especially on the inflammation part of atherosclerosis. Next. As everybody know, go back, please. As everybody know, that the atherosclerosis is a lipoprotein-driven disease characterized by plaque formation at a specific site of the arterial tree. Remember, the heart, the carotid disease, is part of the vasculature of the body, carotid, retina, renal, peripheral. So all of them is one family. What happened in one part, definitely it will happen in the other part. Next. So the pathophysiology of atherosclerosis, there is too many risk factors. Some of them is inherited, fixed, not changeable, and some of them is modifiable. But all of them will meet and cross over in the area of dyslipidemia, or the formation of the atherosclerosis, which is mainly lipid. So the first risk factor I will touch base is the dyslipidemia, which is high lipodensity lipoprotein, lipoprotein A, high triglyceride, and low HDL. The cause of the dyslipidemia, whether it is genetic or acquired, we're gonna go over this. But other risk factor apart from dyslipidemia, which is we really wrote it alone because it is the most important, is family history of hypertension, obesity, diabetes, age more than 45 for a man, more than 55 for a woman, male gender per se, smoking, physical inactivity, diet, and for sure the lack of exercise. All this risk factor will lead to one thing, which is LDL diffuse across the damaged endothelium. Smoking will damage this single beautiful, well-created layer of cells, which is the endothelium. It gives access to the toxic LDL of different type to go in and accumulate in the intimal layer of the arterial wall. So the story will start with disruption of endothelium, access of the LDL, then the LDL in the intima is exodized into lipid. that trigger chronic inflammation. The lipid, they run inside the blood vessels, but once they are in the wall, they are toxic and it will induce inflammation. At this stage, the inflammatory marker will increase in the blood. One of the most important inflammatory marker that today we are really using, to detect early atherosclerosis is high sensitivity, the high sensitivity BCR, CRB, and we're going to talk about it. So then the inflammation will happen. This results in recruiting monocyte to the vessel wall that differentiate to macrophage. So inflammation, monocyte, the regular inflammation process end up by that the monocyte became a macrophage. Macrophage is bad and is good. Next. So the macrophage will phagocyte the oxidized LDL and became filled with fat. Here, we call it foam cells. When the macrophage eat the LDL, it became foam cells. Foam cells is bad. We can detect it by a special kind of IVUS. If we do IVUS, we call it NIRD, N-I-R-D, and it's used now in some of the cath lab, but mainly it's investigational. So the foam cell accumulate in the intima to form, so too many foam cells. They come together, they form what we call the lipid core. When the lipid core, so it form, the foam cells, they accumulate, they form the lipid core. The lipid core is part of inflammation, and this gonna induce some fibrosis around, and that's what we call the fibrous cap. So again, the fibrous cap, it can be seen by some very high resolution CT scan, and it can be seen also by high definition IVUS. Why I'm mentioning this? Because now the entire spectrum is moving toward early detection of atherosclerosis to treat aggressively before a formal atheroma is formed that can lead to rupture or stable angina or a sort of chronic atherosclerosis. So once the atheroma is developed, now we have atherosclerosis. Next. Remember, the atherosclerosis, either it became chronic, calcification come on it, and there will be positive remodeling, which is narrowing of the lumen, or negative remodeling, which is it grow outside, and that's why you see calcification, but there is no narrowing inside the lumen. Or it can rupture early if there is severe inflammation. And a lot of investigation is going on to detect this dangerous active inflamed atheroma. So the complication of atherosclerosis, everybody's know it, either coronary artery disease, carotid, peripheral, chronic kidney disease, and unfortunately, the four of them, they are very common in our countries. Next. So the factor with a strong genetic component is the abnormal lipid or cholesterol level, family history, diabetes, hypertension, as we said, age, and this is then the environmental factor, diet, smoking, and physical activity. We can write a book in each one of these, but the scope of today is just to highlight the risk factor of each one of the, some of them is modifiable, some of them is not. And if you, the whole aim to understand, the pathophysiology is to prevent, if not able, is to detect early atheroma to prevent complication. So prevention of atheroma development is coming by healthy diet, no smoking activity, and the early detection of the atheroma, it's another topic, but atheroma in general, once it's developed, the diagnosis, the disease is established, and you have to deal with it in a different way. Next. So cardiovascular disease is a worldwide disease, and if you look at this figure, 12.7 million case estimated to be diagnosed per year, and the prevalence is around 113 million person walking now, at least in Europe, with atherosclerosis. This number probably similar if we are not larger than this number. It is, if you look, it's almost the same in both gender, with relatively numerically high in women. Next. The disease burden, as you can see in the dark blue bar, cardiovascular disease is the global death, #1 death in the world, more than any cancer, more than respiratory disease, more than diabetes per se. The annual global death from cardiovascular disease, 17 million. 34% of the global death in 2019. More than 75% of cardiovascular death occur in the low and middle economic country. So the more you go south, the more the disease is killing people. Atherosclerosis is the #1, is the dominant cause of a cardiovascular death. Next. Disease burden again, cardiovascular total cases is about 523 million. Atherosclerosis represent about half of them. Death again, majority of the death related to cardiovascular disease related to atherosclerosis, and cardiovascular disease here, life with disability. It is again the majority related to atherosclerosis. Next. Estimated death, 1.1 in North America, 1 million in South America, 1.7 million in Africa and Middle East, 4 million in Europe, 11 million in Asia and Australia. And here, if you read the original article about this number of death, you come with the, conclusion. Each area have their own genetic, have their own environmental changes, like environmental reason, like, for example, Europe and North Europe, alcohol is a big cause of cardiomyopathy and death. And Asia and Australia, Asia, exactly, they have a smaller heart. Africa, if you look, the uncontrolled blood pressure. The South America, the reason why they have a small number of deaths is related to increase in their activity. So they do a lot of work, manual, and they do walk a lot, and physically they are better than anybody else. Next. So the lost economic output by disease, 50% go to cardiovascular disease. Next. Key messages here: atherosclerosis is a lipoprotein-driven disease characterized by plaque formation at a specific site of the arterial tree. Atherosclerosis is associated with a number of complications: eye, kidney, stroke. Risk factors associated with atherosclerosis include abnormal lipid and the rest of the risk factor. Cardiovascular disease is the leading cause of death in the world, and the amount of money we spend every year for established coronary disease beyond you can imagine. Next. 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 Yeah. So I gonna just go back. I just gonna go touch base on the lipid. I will not cover everything. I just gonna highlight some of the importance of lipid and inflammation, atherosclerosis. Next. So in general, the smaller particle of lipoprotein, like the they are more ability to penetrate the damaged endothelium and causing atherosclerosis. LDL, the most dangerous one is lipoprotein A, then the LDL, then as you go higher, like IDL, very low density lipoprotein, and the rest is less atherosclerotic. The protective is the high density lipoprotein, and this is we're gonna look at it now. Why? Because each one have different function. So remember, the LDL family, they are increasing is atherogenic. The smaller of them is the easy penetration through the damaged endothelium and more atherogenic. The next. Yeah, so if you look at the function of each one, this slide is related to the first slide. The LDL, the LDL, which is the one before the last, delivery of cholesterol. So it is job is delivering cholesterol to the targets, like where we need it, myocyte or anything. So on the way to go there, if there is an endothelial injury, it will go and will be accumulated. The high density lipoprotein امشي عكس النهر. It walk in a different way. It take the cholesterol from the target, from the cells, and take it back to the liver. That is why the high density lipoprotein is protective. Next. So as you go smaller in size of the LDL, type 1 or type 2 or type 3, the size matter. So the size of LDL, when it became small, the smaller particle, the smaller type is the more dangerous. And I will tell you the other problem of LDL, what it make, why it is dangerous comparing to the other. Next. Because it contains this apoprotein B. Apoprotein B, it is increase the affinity of the LDL to stick to the insider of the cells. If it is penetrate, this apoprotein B, it's like a glue, make it sticky inside the intima. And imagine, look at the last one, LPA, lipoprotein A. It have lipoprotein B and lipoprotein A, and a small particle. Imagine, small, easy to diffuse, and it have two sticky glue, I call it, apoprotein B and apoprotein A. That's why it is really, really toxic and high atherogenic. Next. So this is about familial hypercholesterolemia, which is, I put it because it's common in Saudi Arabia, according to the paper of Khalid Al-Habib. Next. This is to depict, like how dangerous is the lipoprotein, the A, because it is smaller than LDL, and it contains two gluey receptor, which is the lipoprotein A, apoprotein A and apoprotein B. Next. So this is, the consequences of the atherosclerosis. I like the slides because I want to tell you that atherosclerosis starts from the day we're born. That's why a lot of focus now on obesity in children. Children, we like them to be chubby. It's cute, but that's not right, because the atherosclerosis start from day one. They can have LDL in the first in their intima from the first month of their life, and yes, the body, like the damage they can cause at early childhood is not same as elderly people, but it is really the atheroma starting as early as they are day one in the life. And then, with the time, the atheroma either it became obstructive and you have angina, or it can rupture premature, and this depends on the thin cap. The fibrous tissue will be formed around the foam cells. If you have a thin cap, then the risk of rupture is high, and there is too many modality now to diagnose a thin cap. Next. Again, this just to make you remember, there is too many risk factors. Yes, the baddest one is dyslipidemia, and the baddest of the dyslipidemia is when you have high LDL, and the baddest than LDL is you have lipoprotein A. That's why now too many hospitals, too many cardiac center and primary health care and clinic, they order lipoprotein A. I think it should be routine in all the, like any part of investigation. So yes, we're going to control them with medication. But again, it is not 100% protective, because there is other risk factor like diabetes, like microthrombosis, like triglyceride, inflammation, blah, blah, blah. Next. So you have risk factor, then you have the consequences, which is inflammation. Once the inflammation is happened, then you're gonna have inflammatory marker in the blood. You have interleukin, high sensitive CRB, and like also some thrombi will be formed around the atherosclerosis, and too many consequences related to the atheroma formation. Next. So this is, we discussed it early. Lipoprotein A is bad because it have the apoprotein B and apoprotein A, and these apoproteins, they have too many protein on them, make it easy to attach to each other and to attach to the myocyte inside the intima and to accumulate. As the platelet aggregation, when you have a thrombus, you remember the platelets, they have something on the wall and there is some inflammatory marker, make it more adherent. It is the same here. Next. 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 So the lipoprotein A in general is the most dangerous type of dyslipidemia. Again, it can affect all the vasculature, and it can increase the mortality and morbidity. If you look, the second from down, the lipoprotein A is now connected to the aortic valve stenosis. We believe now that calcified degenerative aortic valve stenosis is part of the coronary artery disease. And this is well established. Next. Next. So the first and the second slide, it tell you that lipoprotein A is genetic, is not related to food, not like the LDL or triglyceride. Lipoprotein A is mainly genetic. So some of the community, they have lipoprotein A higher than the other, even if they are eating healthy food. And this is what explain, when the patient come to you, tell you, listen, I'm doing exercise every day, I'm not smoking, and I'm taking care of myself, but I had heart attack. If you look carefully, these people, they have lipoprotein A in the majority of them. Next. So the lipoprotein A is very bad disease and will related to risk of cardiovascular death and the entire vasculature tree. Next. 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 So let's say that now the atheroma throughout the progression of the atheroma, when it is a formed cells, then it became atheroma until before the rupture. So there, I want to prevent the complication, the progression of atheroma and complication related. Now, the focus is how to diagnose the atheroma early, and you start medication to calm it down, not to rupture, not to become severe coronary artery disease or peripheral vascular disease causing symptom, is by chasing the inflammatory marker. The inflammatory marker, the two of them most well known is the high sensitivity CRB and the interleukin family. Next. As you can see, there are too many under investigation, but the CRB, or high sensitivity CRB, is the most easy and cheap to detect, and it is readily available in the majority of the cardiac center. And interleukin 6, it comes after in the form of easy to measure it and cheaper than the rest. And the majority of the other is under investigation. Next. Next. The high sensitivity CRB, when it is low, it is protective, and it is really related in a linear shape with the level of the LDL. So it's indicate that the atherosclerosis itself is truly an inflammatory process related to the toxicity of the LDL. With these slides, I'm gonna stop, and I hope you enjoyed and you have some idea about the atherosclerosis, the pathogenesis, the risk factor, and the other. So,
Thank you very much.
Shall we leave the discussion? Go ahead, sir.
Thank you very much, Dr. Wael, for this outstanding presentation. And it's very important to understand the pathophysiology of atherosclerosis and the role of inflammatory markers. Recently, this introduced, we have the traditional risk factors, and now we are talking about the inflammatory markers as one of the causes of atherosclerotic process. I think if we have any questions, we can answer, or should I start my presentation as you like?
I think there is question here. Oh, when it began, it's already begun.
Okay, no problem.
So if you guys have any question, submit it. Then we'll take the question and answer after Professor Nabil finish his the elegantly expected talk.
Thank you again, Dr. Wael, for your outstanding presentation. Actually, you paved my way to my presentation, and I'm very happy to share my thoughts about risk assessment and early detection of atherosclerosis with this wonderful audience. Actually, my presentation today, in this presentation, I will cover some fundamentals of atherosclerosis, mainly its prevalence. Dr. Wael discussed very nicely the risk factors and the pathophysiology. I will talk just a little about the prevalence of atherosclerosis, especially in my country, in Egypt. Then I will move on to explore the pathway from identifying these risk factors to employing risk assessment techniques, early detection strategies, preventive measures, and future research. As Dr. Wael mentioned very nicely, cardiovascular disease are the #1 killer. They are the #1 leading cause of death worldwide and in Egypt. And if we look worldwide, we can find that cardiovascular disease are responsible for 1/3 of the total deaths every year. And unfortunately, in my country, cardiovascular disease are responsible for about 1/2 of the total deaths every year. And we have to know that 80% of cardiovascular deaths are due to heart attacks and stroke. And this is a cardio risk project actually done in Egypt. And we found that more than 50% of patients presenting with acute coronary syndrome are considered to have premature coronary artery disease. And we calculated their age. We found that Egyptian patients presenting with acute coronary syndrome are 12 years younger than those equivalent in other European countries. And atherosclerotic cardiovascular disease is expected to cost $1 trillion by year 2030. This is European Society of Cardiology cardiovascular disease statistics in 2021. They found that there were an estimated 47.6 million people living with ischemic heart disease in 57 European Society of Cardiology member countries. Egypt is one of these member countries, and they found that Egypt has the highest ischemic heart disease prevalence. Look at your right side, you found that Egypt at the bottom has the highest ischemic heart disease prevalence. And despite all the effort we are doing, Egypt still has the highest number of cardiovascular disease prevalence and mortality. And these are risk factors for atherosclerosis. As Dr. Wael mentioned, we have actually non-modifiable risk factors like age, gender, genetic predisposition, and we have the classic modifiable risk factors like hypertension, smoking, diabetes, dyslipidemia, obesity, and we have the emerging risk factor, as Dr. Wael mentioned, also chronic inflammatory conditions, metabolic syndrome, elevated homocysteine. Actually, this is the core of my presentation, which is the risk assessment techniques. Let's go to show how can we risk stratify and risk categorize our patients, not our patients, the people or healthy subjects even. We have risk estimation scores. We have the US scores. We have the European scores. We have, in addition to the traditional risk factors, we have novel biomarkers and inflammatory biomarkers. In the US guidelines, they call it risk-enhancing factors or risk enhancers. In European Society of Cardiology guidelines, they call it risk modifiers. So risk enhancers is the same exactly as risk modifiers. Also, we have to consider for 6 specific enhancers, and we have to use imaging for the early detection of subclinical atherosclerosis, and we'll end by the how to risk stratify patients with pre-existing atherosclerotic cardiovascular disease. This actually is the risk assessment tools. We will go through all of this rapidly. The initial framework of atherosclerotic cardiovascular disease risk assessment started with the Framingham risk score. So this is the oldest one, and this was the base of risk scores coming after that. Framingham risk score actually estimates 10-year risk of coronary heart disease based on age, sex, cholesterol, both total and HDL cholesterol, blood pressure, smoking status, and diabetes. And based on these Framingham risk scores, they classified people into low risk if the risk is less than 10%, intermediate risk if the risk is less than between 20 and less than between 10 and less than 20, or high risk if the risk is more than 20. Or in patients with chronic heart disease or other chronic heart disease risk equivalent, they consider these patients are high risk patients. We have the US risk calculator, or what we call pooled cohort equation. This US risk calculator provides 10-year and lifetime risk estimates for atherosclerotic cardiovascular disease. The European Cardiovascular Disease Risk Score, we have the new score, which is score 2, and score 2 all persons, and we'll discuss this later. The advantages of this risk score that they guide clinical decisions for preventive measures. But actually, this risk scores has many limitations that they may underestimate risk in certain populations, especially low risk or moderate risk regions, people. And also, I will show you how these risk tools actually underestimate the risk in low risk and moderate risk people. This is the current US score recommendations. Actually, we have the pool cohort equation used by the American guidelines, and this used for initial cardiovascular risk assessment for those free of known cardiovascular disease or familial hypercholesterolemia. This risk score predicts both 10-year in people aged 40 to 79 years and lifetime for those aged 20 to 59 years of age, risk of atherosclerotic cardiovascular disease consisting of fatal and non-fatal coronary heart disease and stroke. The risk factors included in this US risk score are age, sex, systolic blood pressure, antihypertensive treatment, total and HDL cholesterol, diabetes, and cigarette smoking, but it does provide also input to specify Black ethnicity. So you can go through the internet and just you write the age, sex, systolic blood pressure. If there is any antihypertensive treatment just mentioned, this total and HDL cholesterol, diabetes, and cigarette smoking, and then we will have the risk score at the end. And the current US risk score recommendation that they categorize patients into 4 groups. The first group is considered low risk if the risk is less than 5%, and they recommend this specific group to have therapeutic lifestyle changes. Actually, therapeutic lifestyle changes is important for all the risk categories in this risk group. But for low risk patients, only therapeutic lifestyle changes are recommended. And we have borderline risk and intermediate risk. Borderline risk between 5 and less than 7.5, intermediate risk between 7.5 and less than 20. In both borderline and intermediate risk, they recommend to use what we call risk enhancers. Risk enhancers is recommended in both borderline and intermediate risk, but the class of recommendation for borderline risk is class 2B, and for intermediate risk is class 1. So patients who are considered intermediate risk based on US score should have these risk enhancers to either up class or down class the grade of risk category of this patient, because sometimes we have intermediate risk, and after doing or assessing other risk enhancers, they can be put in a higher risk group, or they can be put at a lower risk group based on this risk enhancers or risk modifiers as mentioned by European Society of Cardiology guidelines. And definitely the high risk patients with a risk score of 20% or more, in this condition, initiation of high-intensity statin is recommended and is class 1 recommendation. The European cardiovascular risk score, actually, we use this risk score in my country. We don't use the US score, we use European cardiovascular disease risk score. And this, the main difference between the old one, the score nil, and the new one, the score 2 and score 2 all persons. In the score, look carefully at the slides and what I am saying, because there is little difference between these two scores. The score 1 estimates the 10-year cumulative risk of first fatal atherosclerotic event in apparently healthy person with no documented cardiovascular disease. Here is the difference, because score 2 and score 2 all person estimate an individual 10 years of fatal and non-fatal. And this is the first difference. The first one was only fatal. The second one is fatal and non-fatal cardiovascular disease events. The second difference is the parameters to measure in this risk score. In the old one, the age was to start with 40 years and the maximum age was 65. In the recent score, the age to start with is 40 years, but the maximum age was 69 instead of 65. And we have a score all person that start with 70 years and end with 89 years. Other parameters like smoking habits, systolic blood pressure are the same, and they replaced total cholesterol from the old score to by non-HDL cholesterol in the recent scores. Non-HDL cholesterol is more specific actually in risk assessment because sometimes we have total cholesterol high, but the HDL is high, so the risk is low. But if we calculated non-HDL cholesterol, this will be more specific in risk assessment. The third difference between the two scores is that the old score classified regions into high and low risk regions. The new score classified regions into low, moderate, high, and very high risk regions. I will show you later what is the position of my country based on these risk regions. The target population to be assessed by this risk score are apparently healthy individuals. What we mean by apparently healthy individuals, individuals with no cardiovascular disease, individuals with no diabetes, and individuals with no severe comorbidities like familial hypercholesterolemia, chronic kidney disease. And the score all persons can be used in individuals with diabetes mellitus. This is how they classified European countries into risk regions, actually based on registry data obtained from different countries about the cardiovascular mortality rates. World Health Organization actually classified European regions into 4 risk regions: low risk, moderate risk, high risk, and very high risk. Look, what is the position of our countries? What's the position of Egypt in these risk regions? We can see that it is in red color. Egypt actually lies in a very high risk region in cardiovascular events. This is because the mortality rate from cardiovascular disease is approximately 1/2 of the total mortality every year. That's why Egypt was considered or was put in a very high risk region. We were talking about the risk score in apparently healthy individual without diabetes mellitus. What about how can we risk stratify diabetic patients? And this is also very important and recently introduced in European Society of Cardiology guidelines. But let's go rapidly with the previous risk score in diabetes. The first one was those from the United Kingdom, UKPDS, developed a risk score for diabetic patients, but as regard US, they don't have a risk score for diabetic patients. But the American College, American Heart Association guideline recommend the use of moderate intensity statins in patients 40 years and above with diabetes, regardless of 10-year risk estimation. And also these guidelines further recommends the use of global risk assessment in those with diabetes to further risk stratify with those at higher risk, given consideration for high intensity statin, aiming to lower the LDL cholesterol to 50%. Added to these risk parameters, the risk enhancers in diabetic patients, they added the duration of diabetes is very important to be added for risk assessment, and the presence of microvascular complications, especially in young patients with diabetes. This is very important risk assessment in diabetics introduced by the European Society of Cardiology guidelines in 2021 as a novel concept for patients with type 2 diabetes mellitus without, and look carefully at this, without atherosclerotic cardiovascular disease or severe target organ damage. This is what we call score 2 diabetes. Score 2 diabetes is exactly like the score 2. They included age, sex, smoking, conditions, systolic blood pressure, total and HDL cholesterol. And in addition to this, they added the duration of diabetes, the level of HbA1c, and the estimated glomerular filtration rate. These parameters added to the original score 2 algorithm, and by this score we can assess or can predict the 10-year risk of fatal and non-fatal cardiovascular events in diabetic patients. So diabetic patients has their specific risk score, which is called score 2 diabetes. And in patient with type 2 diabetes, again, without symptomatic atherosclerotic cardiovascular disease or severe target organ damage, it is recommended to estimate 10-year risk of cardiovascular disease via score 2 diabetes. Look here, as a class of recommendation is one that we have to use this risk score in diabetic patients without symptomatic atherosclerotic cardiovascular disease. Based on this risk score, they classified diabetic patients into 4 risk categories. The first risk category is very high risk group if the risk score is 20% or more, or high risk group if the risk score between 10% to less than 20%, moderate risk if the risk is between 5% to less than 10%, or low risk if the risk is less than 5%. And this is newly introduced by European Society of Cardiology to risk stratify and risk categorize diabetic patients without symptomatic atherosclerotic cardiovascular disease. This is as regards the risk scores, but certain considerations should be taken into our mind when we are using such risk scoring, because current risk scoring approaches focus only on traditional risk factors, as we mentioned, age, sex, systolic blood pressure, non-HDL cholesterol. This is a traditional risk factors, which only provide modest discrimination for atherosclerotic cardiovascular disease. So this risk score, definitely, they have many limitations. One of these limitations is underestimation of the risk in some patients, for example, for certain racial and ethnic group, and those of lower socioeconomic status, and those with chronic inflammatory disease. And also they can overestimate the risk in those with greater socioeconomic status or who often utilize preventive healthcare services. So taking all of this limitation of the risk score in our minds, several risk enhancing factors, again, this is called the risk enhancers by the American guidelines, and we call it risk modifiers by the European guidelines. And these were highlighted again in 2018 guidelines on the management of blood cholesterol to refine risk assessment and facilitate shared decision making. These risk enhancers or risk modifiers include clinical factors and biomarkers. The clinical factors added to the traditional risk factors are the family history of premature atherosclerotic cardiovascular disease, primary hypercholesterolemia, metabolic syndrome, 6 specific risk enhancing factors. I will clarify this later on, what we mean by 6 specific risk enhancers. Chronic inflammatory conditions as assessed by high sensitivity C-reactive protein, chronic kidney disease, and high risk stenosis. Biomarkers include persistently elevated triglycerides, elevated LP little a, elevated ApoB, elevated high sensitivity C-reactive protein, and low ankle brachial index. All of these are considered risk enhancers or risk modifiers. And this is the European Society of Cardiology guidelines about dyslipidemia in 2019. And they mentioned very clearly to use arterial ultrasound to check for carotid or femoral plaques. And this is one of the risk modifier. And second, to use coronary artery calcium score assessment with CT, and this is a second risk modifier in patient with dyslipidemia. And again, this slide was taken from European Society of Cardiology guidelines in patient with diabetes, and they recommend the use of imaging in asymptomatic patient with diabetes. And again, they considered the use of carotid or femoral plaque burden with arterial ultrasound as a risk modifier. Again, risk modifier is equivalent to risk enhancers in US guidelines. And to use coronary artery calcium score, again, as a risk modifier. And I will show you how to use this coronary artery calcium score, especially in low and intermediate risk patients, to either up class or down class the risk category of our patients. Also, they recommend to use ankle brachial index, that may be a third risk modifier, and to use CT or cardiac MRI or MRI for the detection of carotid or femoral artery plaques. how the guidelines implemented these risk scores. Actually, we have two important recent guidelines. We have the 2023 European Society of Hypertension guidelines, and we have the 2024 European Society of Cardiology Hypertension guidelines. Let's see how to implement these risk scores, or how this risk score implemented in these guidelines. Let's go first to the European Society of Hypertension guidelines in 2023. Look at this statement. Cardiovascular risk assessment with a score 2 and score 2 all person system is recommended for hypertensive patients who are not already at high or very high risk. And the class of recommendation is 1. So patient with hypertension should be assessed by these score charts, score 2 or score 2 all persons. And this is from European Society of Cardiology Hypertension Guidelines in 2024. As we know that the classification of hypertension in these guidelines is different from the previous guidelines. And based on this classification, we have patients with elevated blood pressure. So patients with elevated blood pressure who don't have established atherosclerotic cardiovascular disease, who don't have moderate or severe chronic kidney disease, who don't have hypertension-mediated organ damage, diabetes, or familial hypercholesterolemia. In this condition, we have to go to step 2. Step 2 to use the score chart. Or patient with diabetes only, elevated blood pressure and diabetes only, again, we have to go to step 2. What's step 2? Step 2 to calculate score 2 and score 2 all persons. And based on this score 2, we can predict the 10-year cardiovascular risk and to guide the pharmacological treatment for those patients with elevated blood pressure. For example, if this patient with elevated blood pressure is considered low-risk patients, they don't need a pharmacological therapy, just they need lifestyle measures to reduce blood pressure. But if they are considered a high-risk patients, in this condition, both lifestyle measures to reduce blood pressure as well as pharmacological treatment to start after 3 months of lifestyle measures. But in patient in the intermediate risk or moderate risk, we have to go to step 3. What's step 3? Here come the risk enhancers or the risk modifiers. So we have considered what we call shared risk modifiers. Shared risk modifiers between both men and women. These risk or shared risk modifiers include high risk ethnicity, family history of premature coronary artery disease, socioeconomic deprivation, autoimmune disease, severe mental illness, and HIV. This is shared risk modifiers between both men and women. Let's go to a sex-specific risk modifier, sex-specific risk modifier for women. This risk-specific risk modifier includes gestational diabetes, gestational hypertension, preeclampsia, preterm delivery, 1 or more stillbirths, recurrent miscarriages. All of these risk enhancers in women will raise or increase the risk of cardiovascular events. And if any one of these present in women with elevated blood pressure, these patients should have both lifestyle measures to reduce blood pressure, and after 3 months, they have to start pharmacological therapy. So these score charts are very important to guide our therapy and our treatment, especially in patients with elevated blood pressure. And if there is uncertainties about this shared decision, we can go further to assess coronary artery calcium score, as we mentioned before, because if the coronary arteries have some calcifications and the score is 100% or more, this will upclass the level of risk in these patients. Also, we have to use ultrasound to assess for carotid or femoral plaques. We can use high sensitivity C-reactive protein and terminal proBNP and pulse wave velocity. Pulse wave velocity is a non-invasive test recently introduced to assess for arterial elasticity and arterial stiffness, and this can be used even in our outpatient clinics. Again, based on all of this, they guide treatment either to go only with lifestyle measures in patients who don't have any calcium or plaques, or to go with both lifestyle measures and pharmacological treatment in patients with high calcium score or the presence of plaques as detected by ultrasound. In the European Society of Cardiology guidelines in 2024 about coronary syndrome, again, patient presenting with suspected chronic coronary syndrome, they advise to use what we call risk factor weighted clinical likelihood model. What is risk factor weighted clinical likelihood model? This is a risk factor weighted clinical likelihood model contains both symptoms of ischemic heart disease, angina, with given 0 to 3 points, or dyspnea given 2 points, and added to the symptoms of ischemic heart disease, the 5 major risk factors. These 5 major risk factors are family history of premature coronary artery disease, smoking status, dyslipidemia, hypertension, and diabetes. And from symptoms and these risk factors, they develop risk factor weighted clinical likelihood of obstructive coronary artery disease, and they classified patients into very low risk, moderate risk, high risk, and very high risk. Let's go how to use this risk factor weighted clinical likelihood in our patient presenting with suspected ischemic heart disease. Again, by this risk score, patients who are considered to be at low risk, not very low risk, at low or moderate risk, in this type of patients, we have to ask for a CT either to assess the calcium score or to assess obstructive coronary artery disease by CT coronary angiography. And in patients who are considered to have moderate or high risk by this risk factor weighted likelihood of obstructive coronary artery disease, in this condition, we have to ask for functional imaging to assess myocardial ischemia. And if the risk score is very high in this type of patient presenting with chronic coronary syndrome, invasive coronary angiography and FFR is recommended. So the use of risk score is very important to guide our treatment. Now we have the low risk, moderate risk, high risk, and very high risk. And based on this risk category, we can guide the treatment or the choice of the treatment for such group of patients. Let's go rapidly for the use of this risk factor clinical likelihood. In a very low risk patients, definitely no further testing is recommended. But for low risk patients who have a risk more than 5% but less to 15%, we can choose between CT coronary angiography to detect subclinical atherosclerosis or to use a calcium score. And for moderate risk patients, we choose a CT coronary angiography for the detection of subclinical atherosclerosis. If these patients have subclinical atherosclerosis, definitely there will be up classes to higher risk group, not a moderate or low risk. But if they don't have any evidence of calcium or any evidence of obstructive coronary artery disease, they will be downclassed to a very low risk group that they don't need further testing. And this is a very important study. Explain again what I have said before, that this is a review conducted across 1,500 patients who experienced a myocardial infarction at the age of 50 years or less. They found that more than 50% of these patients presenting with acute myocardial infarction were considered low risk immediately before the events. That's why it is very important to use risk modifiers or risk enhancers or imaging technique in low risk group to either upclass or downclass this risk group just to prevent cardiovascular events in this risk category. What about the early detection strategies for subclinical atherosclerosis? We mentioned this before, the importance of early detection, because a patient with subclinical atherosclerosis, actually, they are lacking symptoms. Atherosclerosis in this type of patients often shows no symptoms. That's why it's very important for early detection of subclinical atherosclerosis in patients who are asymptomatic or patients who are considered low or moderate risk. And again, this is a very nice slide, actually, because Always we are talking about primary prevention in apparently healthy people, and we are talking about secondary prevention in patients with established atherosclerotic cardiovascular disease. But actually, we have a group of patients in between those primary and secondary prevention. This group of patients called intermediate population. This intermediate population is the best described as those with advanced subclinical atherosclerosis because they don't have symptoms. And we don't know whether this patient can be considered as a primary prevention patient or this patient can be considered as a secondary prevention patient. If this patient actually have subclinical atherosclerosis, we have to deal with such patients as a high or very high risk population and to deal with this patient as a secondary prevention patients. And the diagnostic approach for this intermediate group, as we mentioned again, either with some inflammatory markers like high sensitivity C-reactive protein or the imaging technique we mentioned before, like the carotid ultrasound to detect plaques or coronary artery calcium scoring or even CT coronary angiography to detect obstructive coronary artery disease. The use of ankle brachial index in this patient is also important, and advancing imaging like MRI and PET, all of this imaging technique can be used for the early detection of subclinical atherosclerosis. And this also slide taken from the US score, who should undergo calcium scoring. They mentioned that patients who are considered low risk by the US score, the risk is less than 5%, these patients is recommended to have a coronary artery calcium score, either to confirm low risk status if they don't have any calcification, or to upclass risk based on the coronary artery calcium score if they have calcification. So low risk patients, if they don't have any calcifications, they will still a low risk patients, but if they found to have a calcification by coronary artery calcium score by CT, this will be upclassed to a higher risk group and should be treated according to this. What about risk assessment methods in secondary prevention? And this highlighted in the European Society of Cardiology guidelines that patients with established atherosclerotic cardiovascular disease, either clinically, either they present with unstable angina or acute coronary syndrome or myocardial infarction, or unequivocally by imaging like CT or MRI or ultrasound, they found to have plaque burden in coronary arteries or in the carotid or femoral arteries. These patients are already considered a very high risk group. They don't have risk scores. They don't need to have risk scores. They are considered very high risk group, and we target an LDL cholesterol of less than 55 milligram per deciliter and 50% reduction. What about the preventive measures? Actually, Dr. Wael mentioned this very nicely. The preventive measure and managements start with the lifestyle modification with healthy diet, regular physical exercise, smoking cessation, and weight reduction, and pharmacotherapy. All of us know what we mean by pharmacotherapy: statins, antiplatelet therapy, blood pressure control, and blood sugar control, and emerging therapies, new drugs targeting inflammation. Actually, we have recently some studies about some drugs targeting inflammation and targeting interleukin-6 and high sensitivity C-reactive protein to help plaque stabilization. Again, this is to summarize. Patients actually who are considered low risk are recommended to have only lifestyle intervention. Patients who have cardiovascular risk factors like hypertension, dyslipidemia, diabetes, obesity, smoking, they have to have treatment to control or properly control the risk factors. Otherwise, they will move from low risk to moderate risk to have subclinical atherosclerosis, and then will move to a higher risk if they have cardiovascular clinical events, and to a higher risk if they have end-stage cardiovascular disease. And this is the future directions, and the research recommended. The first one is a very important one, that we need to have personalized risk assessment using genetic data, because genetic predisposition to atherosclerotic cardiovascular disease is a very important risk factor for atherosclerosis. We don't have this nowadays, but we hope to have this personalized risk assessment using genetic data in the future. Also, the development of novel biomarkers for better early detection of atherosclerosis, imaging technique, also for detailed plaque analysis, integration of artificial intelligence and machine learning to predict risk and tailor intervention. Ongoing research aims to transform preventive cardiology. And this is my conclusion. Number one, it's very important to assess the risk factors, as mentioned by Professor Wael, very early in our patients, and to combine clinical, imaging, and molecular tools, which are very crucial for the effective management and prevention of atherosclerosis, leading to improved health outcomes. The second is the early detection of subclinical atherosclerosis, because early detection of subclinical atherosclerosis can prevent serious complications of acute myocardial infarction and heart failure. That's why innovation in imaging and testing are vital. And also we recommend to have ongoing research and innovation, which are very essential for advanced treatments and improving patient care in atherosclerosis management. Greetings from Egypt, and thank you for attention.
What a great talk, Dr. Nabil. And I really enjoy it. I really enjoy it. MashaAllah, tabarakallah. Very comprehensive. And I wish from the organizing committee to email this lecture to everyone so they can keep it in their library and to learn from this comprehensive man. You did amazing, Dr. Nabil. MashaAllah, tabarakallah.
Thank you, Dr. Wael.
If there is any question, you guys, please submit your question and we'll try to answer any question. I think it's well explained by Dr. Nabil. I want just to add something. Here in Saudi Arabia, over the last 3 years, we have collected most of the publication done locally at the level of Saudi Arabia. And based on that, and based on the international guidelines, we wrote a couple of guidelines, and dyslipidemia guidelines and consensus document. And we came up under the supervision of the Minister of Health with a nice simple risk calculator for the people who's practicing here or in our region. I can share it with you. You can look at it. It's a very simple one. Hopefully it is here.
Actually, Dr. Wael, we need we need to have risk calculator for our area, for the Middle
Yes.
East, because actually the population are different from the European, but unfortunately we enforced to use their risk calculators.
Yes, absolutely. So
nice.
do you see it? Do you see it, guys?
Yes. Yes, I see it.
Yeah. Yeah. I can share with you also the barcode of this, and you can apply it.
Please,
Yeah.
Dr. Wael. I think this is very important, and we can I can spread this information in my country because I think this is very important to have risk scores again for Arab people and for Middle East. Can you share it again, Dr. Wael? I think there is a problem with the internet. I think there is a problem with internet for Dr. Wael. He is not with us now. The organizing company, can you connect with Dr. Wael? Okay. Or we can finish this event and this webinar. And any question from the audience, I'm ready to answer. And I hope you have some important information about the risk assessment, the importance of risk assessment in healthy people coming to your clinic. And it's very important to use these risk scores to assess the risk category, because some patients who look healthy, but they are considered very high risk if we calculated the risk score of our patients. And this definitely will guide our treatment choice for such patients based on this risk category. So it's very important to know how to use the different risk scores, the risk enhancers, the imaging techniques based on the different guidelines, specifically European Society of Cardiology guidelines. Actually, in our country, we follow these European Society of Cardiology guidelines. It's nicely to be used and easy to be used, actually. Anyone of the organizing company?
Doctor, he got disconnected. If you want to.
Because Dr. Wael is not with us now.
Yeah,
I think there's a
he got
problem.
disconnected. He got disconnected, doctor.
Yeah, okay. So we finish. We come to the end of this important webinar. Again, I have the pleasure to share this webinar with my distinguished speaker, Dr. Wael. Again, I would like to extend my gratitude to Bayer Company for inviting me to give this presentation. And again, I'm very happy to be able to share my thoughts about risk assessment and early detection of atherosclerosis with this wonderful audience. And I'm ready to answer any questions, even through my email. Thank you very much. And we come to the end of this webinar, and see you later, and see you in Egypt, in Cardio Egypt conference in 2026. Thank you all, and good evening and goodbye.